Hello, hello, hello. Hey, everybody. Happy Tuesday. Dr. Cindy Duke, your Johns Hopkins Yale physician uh, scientist, who is here today to talk all about more coronavirus conversations, tongue tied. But I figured out our connectivity issues, so I'm super excited. Today, we're talking more specifically about physical and rehabilitative needs for patients who have been diagnosed and hospitalized, usually for COVID-19, and then discharged to home. That's part of the conversation that we haven't been having. And certainly, we've all been seeing the numbers, and somewhere between 25 to 35% of patients with coronavirus are recovered. But part of what we're not hearing is what happens when someone's recovered. What does that mean? And what are people actually seeing out there? So today I'm joined by three of my physical therapy colleagues. We may have a fourth joining us as well. So it's going to be a fun conversation. And so without further ado, so that we can all get the most out of this, I'm going to introduce in no specific order. First, Dr. Rich Severin, Dr. Jason Falvey, and Dr. Monique J. Caruth. Hi, guys.
Hey, thanks for having us on here.
Thank you so much for joining me. And thank you so much for what you're doing, because you guys are working really hard, guys.
Yeah, thank you.
So as we go along, before we start, talking about everything that we need to cover with our audience, let's just introduce who we are. So let's start with Dr. Rich. Tell us who you are.
Great. So my name is Rich Severin. I'm a physical therapist and researcher at the University of Illinois at Chicago and Baylor University. So I am faculty at UIC, where I'm finishing my PhD. As we kind of talked into the lead up for this episode, my research is in cardiorespiratory physiology and obesity. I specifically work with the bariatric population, of which many in my clinic here in Chicago are primarily African American and Hispanic populations, which were, as we will get into later, maybe we're particularly impacted by this condition, or this pandemic. And I'm also faculty at Baylor University in their hybrid doctor of physical therapy program, which is also unique because for those of us probably listening in academia, the transition to online coursework is something I've been doing for the past 5 years. So it's interesting how things just kind of fall in line sometimes. Yeah. But I'm local here in Chicago.
Wonderful. And thank you for joining us. Dr. Jason, tell us more about you.
I'm Jason Falvey. I'm a physical therapist and clinician scientist, currently a research fellow at Yale University, New Haven, Connecticut. So we have that Yale connection in common. Yes. My research is on post-ICU syndrome and how patients that are leaving the ICU or that were mechanically ventilated move through the post-acute and outpatient rehabilitation spectrum, looking specifically at access to rehabilitation and disparities in use among different neighborhoods and rural urban populations specifically. So that's the direction my research has started to take me.
That's really cool. And I would imagine a lot of that is further highlighted during this pandemic.
Yes, I think there's a lot of healthcare disparities that are being highlighted, and the rural and urban infrastructures for healthcare are definitely being challenged in very different ways. Having grown up in a very rural, very poor community, they're having more unique challenges in Maine than other places that I've lived. So.
Indeed. Oh, I look forward to this conversation. And Dr. Monique, tell us about you.
Well, I work primarily in home health in Maryland and primarily in Prince George's County, which is largely populated by African Americans. So we've been hit very hard by the coronavirus. So I've been treating positive cases in their homes for the past couple of weeks.
Yeah.
And, so I just do home health for now, but I've done inpatient and outpatient care.
Yes. Now, before we get into the nitty-gritty of COVID-19, I think what most people looking probably didn't realize is that many physical therapists are doctors of physical therapy. So can you guys tell us a little bit about what that entailed? And for the younger viewers who might be interested in becoming doctors of physical therapy, earning this DPT credential, what's that like?
Rich?
Yeah, I guess I'm going to speak to because I'm guess the only DPT faculty member here. But so it's a clinical doctorate. It became the mandatory entry-level degree in 2015. It's existed since 1992. I believe the first program was it's either Creighton or USC. I can't remember, but it's been the majority entry-level degrees since I think the turn of the century, maybe, and that's every program is a DPT program. So. It covers, some of the same things you'll see covered in medical school or other professions, your anatomy, your physiology, but we, spend a little bit probably more time on exercise prescription, a bit of neuroscience, cardiovascular, physiology and pulmonary physiology. And programs are 3 years. So it's usually you have 2 years or so of didactic coursework and then about a year intermix. Sometimes it's at some programs it's all 1 year. It's just clinical. Some it's like you do part between year 1 and 2, and then year 3 is clinical. So it depends on the program. And there are also some programs that are hybrid and online. So I teach for Baylor University, which is an accelerated program that does theirs in 2 years, which is a little intense for some of our students, but it's been uniquely situated, especially with this pandemic, that their lecture and didactic and materials delivered online where they do labs and in person. So there's a few different models out there. There's a lot of programs. I think we're at now roughly 245 programs, I think, around there, give or take, across the country. And yeah, it's a noble profession. And I don't know. I'm not sure other details to cover, but yeah.
My fault.
Yeah.
It's pretty diverse, which is exactly as you described, but also people can subspecialize. No, I mean,
absolutely.
What you guys have described, you sound subspecialized.
You graduate with we call an entry-level doctorate, but there are clinical specialties like I have mine in cardiovascular and pulmonary. Jason's has his in geriatrics, right, Jason? And there's neuro, orthopedics, sports, pelvic health.
Yeah.
Pediatrics, electrodiagnostics. I think there's 10 clinical specialties, and there's residency training, fellowship. It's not mandatory like medicine, right. But we're pushing it. We're growing them. I did 2 residencies myself, so there's a lot more options available for new graduates to get specialized training.
Wonderful. And just to clarify, for those listening, you do a college degree first before you go to PT school, correct?
Yeah, it's a little bit different than other places around the world, where it's usually maybe a 5-year bachelor's degree and then some optional, master's programs. Ours, we require a bachelor's degree prior, and then it's a post, a graduate doctorate, so a professional doctorate.
That's awesome. So each of you did that and then subspecialized and decided, okay, this is where I'm going to head. This is what I'm going to do. How did you respond to COVID-19 when you first heard of coronavirus and COVID-19? What was it like for you guys in the physical therapy community?
Monique, you want to start?
Well, to be quite honest, we realized that it was for real. It wasn't fake. I was not sure how patients would actually present themselves in the home. But based on the clinical findings from in acute care, I know they would be really fatigued and weak. I just didn't realize it was going to be that bad when I actually got into the home. And compounded with the fatigue, the weakness, the inability to sit up for long periods of time or to walk, people are mentally drained and depressed. So it's a lot to handle, and it's draining on caregivers, family members in the home, the patient themselves. And, sometimes you feel a little defeated, but you celebrate every little step that, a person takes. Like one patient today walked 10 feet, and that was great for us. And, we appreciate that.
And was that a patient who was previously healthy before COVID-19?
Yes, completely healthy. The only issue that he had was hypertension and diabetes, but it was well managed. in his situation, unfortunately, his wife tested positive, but she was asymptomatic and passed it on to him, and he has been battling it since.
And that brings me to my question, which is, are you afraid when you go to take care of these patients? How do you protect yourself from transmission when you have to head into the homes or see them at the outpatient facility? What are you guys doing to protect yourself? Because a lot of what you do does involve hands-on work, meaning you're within 6 feet of the patient.
Yeah. You are very close because you have to help them get out of bed. You have to help them sit up, give them support, turn them prone. Actually, sometimes you have to perform chest PT depending on if they're still having a lot of mucus on their chest. So you're pretty close. It was scary at first. I held off as long as I could possibly, not treating, because I don't want to have people that I was around be at risk for getting infected.
Right.
And also my family members.
Mm-hmm.
Here, but in discussion, they were like, I don't think do it. But eventually I gave in because I realized people needed help and the cases kept coming in and other people were refusing them. So I finally gave in and said I would start treating.
Mm-hmm.
We have to wear full personal protective equipment.
Mm-hmm.
So before I enter the home, I have to put on headwear, face shield, N95 mask, gloves. We usually advise to double up with the gloves. Gown, shoe covers. The patient and all family members that are present during treatment must wear masks.
Good.
So to prevent them from, if they're coughing or anything like that, from getting that onto us. We also have we have to take vital signs. So instead of taking our equipment in, we actually leave equipment there for the patient. So we leave a thermometer, blood pressure cuff, pulse ox there in the home, and that's for that particular patient to use. So that reduces the risk of us having to take in our bags or equipment in there. If the patient needs assistance with a gait belt, we leave a gait belt for that patient there as well. So we're not taking stuff out of the house to carry to other homes that we have to treat patients who are not positive. And basically wipe everything down. As soon as we leave the house, we have to take everything off, put it in a garbage bag and get rid of it. I also spray myself down. And I have a plastic lining in the car, on the car seat and on the steering wheel to prevent any transmission of stuff that I get rid of as soon as I'm done for the day. I take my clothes off in the garage and head into the shower right away before I come upstairs. So that's basically what I've been doing. I think she got disconnected.
Did we lose her? Yeah, I've had similar, we haven't been treating as much COVID-19 active cases, but we've had a lot of community transmission in New Haven, Connecticut. We're one of the top 10 counties in new cases and in deaths. And we have very close proximity to New York City. So, we're a high risk community. And even our patients who are non-COVID-19 survivors, we're taking a lot of extra precautions in terms of equipment and cross-contamination risks. And, there's a substantial limitation on the number of visits we're providing to even non-infected patients. The spillover effects, which are disproportionately hurting older adults who are staying inside more, are more likely to be homebound, and for whom inactivity for even short amounts of time is pretty detrimental to health. So it's been a pretty major concern for me in terms of who we're missing and who's not going to the hospital and who's not getting medical attention. The people who are at risk for falls, at risk for deconditioning, just because there's such a shortage of equipment and it's rightfully being, requisitioned and used by people at the highest risk that are treating active cases. But it's really, there's such a spillover effect for people not seeking or receiving necessary care as a result. And that's really the concern that I've been having. That there's just not enough personal protective equipment to protect therapists that are trying to provide care to these vulnerable populations.
Yeah, and I think it speaks to some of the advancements we've seen or leveraging of telehealth. So what we've been doing with our clinic services, we've, the tough thing is that all of this is kind of being done on the fly, right? We didn't have a telehealth system in place really for any of our services, but we've, out of kind of the ingenuity of chaos, right? We've developed something that we can deliver to reach those populations. Jason's absolutely right. Like, we are hyper focused on taking care of these very critically ill patients with this pandemic, but let's also not forget that we live in a country where 6 in 10 people have a chronic disease, 4 in 10 have 2 or more. So not all of them are getting COVID and in the hospital. They still have ongoing needs, especially geriatric populations. Those are those with pre-existing issues. We still need to find a way to continue to deliver care while protecting ourselves, protecting the patients, because you're right, like we can't, we need PPE for those facilities, and it's just, we need to find ways to be creative with how we're delivering care. And I think the telehealth option's been useful. The tough thing is, like, not all of our patients have, the ones I work with or primarily from the south side and west side of Chicago, like, might not have, a smartphone or tablet. Good number of them do, but that's also an issue. Like, how do we get the infrastructure in place to get what we need to deliver these services at a high value too, right? Because there's still cost to everything we do. So
how does PT work in terms of how does telehealth and physical therapy work, especially in a patient who may need some assistance? Do you have some sort of extender in the home still that's helping to do some of what you need with the patient?
Yeah, it's going to be different. I've benefited because I've been sort of doing this kind of, I guess, just with my family members whenever they have something or friends, Skype or something like that. We've been doing this for the better part maybe of 10 years when I started PT school. Mm-hmm. You got to get used to giving people instructions and demonstrating things and realizing there's just some things you're not going to be able to do virtually. If someone needs, hands-on things, right? Maybe that's not the best platform. And maybe that's someone that would need to come into a clinic, like in a patient, acute stroke, that probably needs someone there to kind of guide them along. But most of our stuff regarding a variety of low back pain, or the patients I work with who are seeing mainly for arthritis or just deconditioning, preparing them for their surgery, we can manage a lot of that from a telehealth platform. And it's been done for exercise training for years. There's a group in Scalvini in Italy and Birmingham in the UK. They've been doing this for years for cardiac rehab. But the problem is with them, they would send the patient, an exercise bike, monitoring equipment. They'd send them the camera, send them the stuff, and there'd be things built in. So I think hopefully once this resolved, we'll look at doing that, because invariably this will happen again. We need to be prepared for it.
Need to be prepared.
Yeah.
So in terms of securing that personal protective equipment, are there any agencies or any NGOs or not-for-profits or anything that's stepped up to help?
County, the Maryland Department of Health have actually supplied personal protective equipment to agencies and to individual residential service agencies for us to go out to provide care because it's needed. One of the issues is that everybody is actually trying to get the equipment. The hospitals,
right,
homes, home health agencies, and other agencies that just provide like personal care and companionship to a lot of elderly residents in the state. So it's
a huge shortage.
Yeah, they're rationing a lot of stuff out, but we are getting stuff from the Maryland Department of Health.
Well, that's good. So Department of Health. How about you, Dr. Falvey, in New Haven? What's been your experience? And from your colleagues, what have you heard?
Yale has, been fortunate that they haven't had to ration equipment yet. I mean, we get updates every day from the university and from the hospital system. But we've run low on a substantial amount of gowns and N95 masks, and we've leveraged international connections that we have through the university with our study abroad partners in China and in South Korea. We've actually leveraged those kind of relationships to order and get personal protective equipment in, which is a challenge when other states are competing for that, other companies, and even the federal government is taking personal protective equipment at times and requisitioning or redirecting shipments into the national warehouse. So I think, I think every community is stepping up. There's just not a massive coordinated effort. So, but we've had challenges for sure, and we've definitely, in some of the home care and long-term care organizations, have definitely had more of a grassroots effort. In home care, we are rationing some equipment and trying to be really conservative with the number of patient visits that we do, because home care agencies in particular run on a pretty small profit margin and just don't have the ability to have tons of equipment in store.
Yet it's necessary equipment for a very necessary and essential service.
Yes, so that has been, I've been really concerned nationally how many facilities have defined physical therapy as non-essential. There's many assisted living facility communities, many long-term care facilities who have shut their doors to any non-essential medical personnel, and that has included physical therapists at times.
Wow.
So we've had a major advocacy effort on board. We've written a perspective piece in our journal to really lay out the case for that there are some patients for whom face-to-face therapy is necessary, and for whom we really do need those pieces of equipment. Telehealth is a great option for many people, but for people who are cognitively impaired or perhaps don't have a caregiver in rural areas where broadband internet access isn't available, or for socioeconomically disadvantaged populations, or patients living in congregate living situations where telehealth just can't provide the kind of services and the kind of privacy that are necessary.
Yeah. So what are you seeing in those situations where people are in rural settings or socioeconomically disadvantaged situations? What sort of accommodations are being made either by the private community or some state entities? What are you seeing?
Honestly, they're just, a lot of services are being not delivered to those populations. It's very difficult to access rural communities in terms of home care especially, but for a lot of other services, rural hospitals are particularly vulnerable to financial impacts of cutting elective surgery. So they're already running on short staff and short equipment. And then, how you deliver to socioeconomically disadvantaged communities, really, it's a lot of boots on the ground. It's very difficult to call somebody on the phone in those situations. They often don't have phones. They often have cell phones that have, preloaded minutes, and they're not able to get to a store that sells them, or they don't have money. So it is a real concern that we have a lot of people who are going without necessary services. Emergency room stroke and heart attack visits are going down, and I guarantee you those people are still having strokes and heart attacks. They're just not seeking healthcare, and I'm going to guess that is probably disproportionately affecting minority and high-risk communities and densely packed urban areas where people are just afraid of getting coronavirus because of the public spread. So I'm really concerned about follow-up care for them too.
Yeah, no, that's a very scary thought, which is that people may be home with stroke symptoms, heart attack symptoms, but not seeking care out of fear of getting the virus.
There's reported calls from patients as well. And because I get calls, patients said I fell, and, you tell them, you need to call the doctor, see what they suggest, but they would not go to the emergency room to get an x-ray or even to patient first or any ambulatory unit. Also, to piggyback on what Dr. Jason was saying, a lot of agencies have recommended that to reduce the usage of PPE, we provide therapy once a week. But when I've gone in to do evaluations and I see how weak some of the patients are, Because typically, depending on the progress level of some patients, after discharge from a hospital, they would send somebody who is pretty weak and can't do anything for themselves to an acute, a SNF, skilled nursing facility versus home. So they can get therapy like almost every day. But because there's a risk of spreading COVID to other patients in nursing homes, they are not allowing COVID positive patients to be admitted to skilled nursing facilities or subacute rehab. So they're sending them home.
Wow.
So for instance, I've had to defy the one visit per week frequency request and do 2 to 3 times a week with some patients, just so that they will not decline further or have to go back to the hospital.
My goodness. So speaking of that, what are you guys seeing in terms of some of the more common issues as patients get discharged, particularly those who are, let's start maybe Dr. Rich, with those who are in the intensive care unit. What are you seeing in terms of those patients who are heading home post-intensive care for long times?
Myself here, yeah. So, as I mentioned, I'm primarily on the outpatient side. I have plenty of colleagues. We're kind of bummed Dr. Ridgway wasn't able to make it here because he's kind of on the front lines here. But from what I've heard, there's been a mixed phenotype of how these patients are presenting. I mean, let's just be honest. This is a wild virus. It's affecting multiple different systems in patients with underlying issues already. So we're even hearing that there may be some Guillain-Barré-like presentations in a certain sense, where we're seeing these like almost profound, neuromuscular weakness. There are also obviously the pulmonary concerns, right? So patients are very short of breath because of some of the, profound inflammatory changes in the lungs, which may lead to other long-term fibrosis and other issues. The big concern is the stabilized patients who have the most severe symptoms. They go on a mechanical ventilator, positive pressure ventilation, which if you're on a ventilator for longer periods of time, a lot of issues can happen to you. It builds up secretions because of the positive air pressure that goes in the lungs, which prevents mucus flow. So you can have issue of secretion build up. You can have barotrauma of the lungs, already on something that's already have all these inflammatory changes.
Yeah.
The other side is you see within the first 18 hours in many patients, a condition we call ventilatory induced diaphragm dysfunction, or VIDD, which causes profound and rapid atrophy and weakness of the respiratory muscles. And then you may also see changes, in the skeletal muscles. So profound weakness, maybe some issues with weaning from the ventilators. Again, because you look at the case mortality rate for this population, I think like 50% of them are obese, or the statistic, but a high number of them.
High number.
High number. And those patients in general are very difficult to wean from a ventilator. It's a bit of an operative risk. And then, they're a large number of them are on ventilators. So it's a bit of with an acute illness. So we're seeing, it's been a mixed bag, but the pulmonary concerns, the weakness, and then we're finding now, there may be even some neurological changes. And then, of course, obviously the clotting, which has kind of gained some recent attention, the hypercoagulable state. We're even thinking maybe microvascular changes, myocarditis. It's wild virus for sure.
And so that means, for a lot of us, when we hear people are recovered, we assume they're back to their normal. And it sounds like no.
Yeah, it's going to be
in your head.
Yeah, I know. I talked about some paper we had published just recently in the American Journal of Medicine, and we have a few more coming out. But yeah, even if we get past we address the physical body structure impairments these patients sustain.
Yeah.
Right? Even if we remove the underlying pre-existing conditions they had, which a lot of them have.
Right.
To unpack and process being hooked up to a ventilator in an ICU, close to death, it's a harrowing experience for most people, and it's a hard thing to process. Notwithstanding that you may be in an ICU that you may not have normal circadian rhythms because you maybe don't have sunlight, right?
Right.
So the ICU delirium, Dr. Jason will talk a lot about this himself, compared to research, the post-ICU syndrome that patients get even without COVID. So even if you get past the physical manifestations, the affective domain, affective domain are profound.
Profound. So, Dr. Jason, what is that? What is post-ICU syndrome?
Yeah, it's a good question. It's something that's definitely been in the news more. I know I've seen articles in the Washington Post and NPR. It's really it's a sequela of symptoms. It's physical, cognitive, so the way you think, and emotional dysfunction that kind of persists after the physiological damage has kind of resolved. So once your infection has resolved, your sepsis has resolved, and the medical issues that kind of brought you into the ICU, there are these lingering issues, and they last for 6, 12, months or more. I mean, there's papers out there that say 5 years later, even healthy younger people are at 70% of their maximal exercise capacity compared to healthy, normal adults. So it certainly is a challenge. And I think there's another complication with COVID from a policy standpoint that's making it even worse, is these patients have prolonged ICU stays for all of the reasons that Dr. Severin mentioned, but then there's nowhere for them to go after hospitalization. Skilled nursing facilities aren't taking them without 2 negative tests, and often, so it becomes challenging to place patients. So they're in the hospital for longer, locked in a room because they're still infectious, not receiving therapy in many cases to preserve PPE. The deconditioning becomes an issue. So we're iatrogenically increasing the deficits that they have, and they often don't have access to rehabilitation after discharge either, because either home care is not available or can't safely handle these patients, or the patients are just too scared to have people coming into their house and reinfecting other members of their family. So, valid fears that I think really add challenge from a policy standpoint, because we just don't have the post-acute care infrastructure ready to flatten the disability curve that really is starting to manifest after the infection curve kind of subsides.
And that's a major thing. Yes, Dr. Rich.
Do that too, and I know Dr. Jason will, Jason will. I know Jason personally, so I'll call him Dr. Jason. So, and Monique too. So, these were issues even prior to this, to the handoff. In Jason's written quite a few elegant papers on this. That this is a big problem already.
Yeah.
All this is just hopefully that we use this situation as a learning point, because this was a problem even before.
So, Dr. Jason, if you were in control of making the policy, what would you do differently here? Because certainly COVID-19 isn't going away next week or next month. This is going to be around for the immediate future, at least until we have a truly effective and widely distributed vaccine and effective treatments. So what do we do in the meantime? Because it does not sound like this is adequate, sending people at home, particularly if they don't have caregivers and if they're limited in terms of how many physical therapists are available to them. So what would you do, and what can those who are listening advocate for when they talk to their policymakers, or are in their town halls, or the elections are coming around and they're asked questions? What can they ask about this?
Yeah, it's a great question. And I think one of the things that I've really given a lot of thought to and pushed, and Dr. Grabowski from Harvard Med School, who's a post-acute care researcher, has also pushed something similar, is having rehabilitation at home models where you can provide more intensive rehabilitation, be reimbursed at a much higher level, similar to a skilled nursing facility, but provide more intensive care at home. Our current home care infrastructure specifically defines the needs as intermittent, need for nursing and physical therapy care. So there's actually a cap on the amount of hours you can provide care to patients at home, which I think for these patients is really, challenging. And if we could put, many of these CNAs that are maybe out of work from long-term care organizations, or out of work from other places where there's a high infection rate, we could actually, we could redistribute staff from outpatient physical therapy clinics and from other places that are being underutilized right now, and have COVID-specific rehab at home, or COVID-specific outpatient facilities that we could provide all the necessary care in one place and really preserve PPE to the greatest extent possible.
That sounds like a brilliant idea. I hope someone's listening who can do that. Now, in the meantime, you mentioned the facility and the care that's needed at home. How do you, the team members, craft that plan? So, as you said, there are different manifestations of COVID-19. Some people have the vascular issues, some have more pulmonary, some have pulmonary plus cardiac, some have, like you said, that Guillain-Barré type syndrome where every system was impacted, particularly neurological, so they're not even maybe mobile. How do you determine what you're going to do for them at home, Dr. Monique? 1 second, I have to unmute you. There we go.
Well, when you go in for the initial visit, you do a complete assessment, and you ask the patient and the caregivers what their goals are, and you work from there. You develop a plan of care for that patient to meet those specific goals. So depending on how they present, you determine if you're going to be working on balance, walking, pulmonary PT, but most of the patients and the family members just want them sitting up, which they're having problems doing. Wow. And just moving around. The longer they stay laying down, the weaker they are going to become, and also have a risk of developing pneumonia again, just laying in the bed. So it's a catch-22 situation because they're mentally drained, they're weak, and
you need to get them up.
We need to get them up. So
wow.
We don't have a choice. And prior to, in terms of the policies, in January, CMS had cut rehab visits and reimbursement.
Medicaid services, right? On Medicare?
Yeah. Yes, they did. So a lot of agencies were actually reducing physical therapy visits. So for this to happen right after that happened, it's crazy.
Wow.
Caregivers are demanding more visits and frequency of visits, but the agencies can't provide it.
Right, because they're limited by Medicare.
Yeah.
Right. And these patients you're seeing, are they primarily elderly or previously infirmed patients?
Actually, we're seeing a wide range of patients. We're seeing people in their 40s, 50s, 60s. The oldest COVID patient that I have is 82.
But they're people young in their 40s, etc., coming home with weakness and needing different types of long-term care just to rehabilitate.
Yeah.
Wow. So with all this going on, docs, and recognizing that there's not enough policy, there's not enough PPE, it just sounds like you're, trying to push a stone up a very steep hill. What is it that we, the public, and the patient population can do to help you guys?
Stay home.
Yeah.
Stay home, email your senator and congressperson.
Yep. Yeah. No, I agree. Like, the public health requirements, like, it helps protect you as the public, but it also helps protect your healthcare providers. Because if you start infecting your doctors and your therapists and your nurses and it goes around in a hospital, you could shut down a hospital pretty quickly. So I think it is, that's the number one thing you can do. Advocacy. A lot of us are on the phone with our legislators. I've had at least 1 to 2 meetings with representatives in the state of Connecticut to really share with them the concerns about PPE and telehealth and the need to be able to get reimbursed, because currently Medicare does not reimburse physical therapists for providing telehealth to patients in most settings. And that's a real concern because it either increases risk to patients trying to get out, or more commonly, they forego really important care like fall prevention, like cardiac rehab. That's important. And people that lose function or decline in function after a hospitalization, they have a very high risk of hospital readmissions, which could occur at a time where there's already high surges and high use of the emergency room. And if they're still infectious, that presents a risk to everybody that they come in contact with during that hospital readmission, from a fall or a fracture. you know, doing a hip fracture repair surgery on somebody with COVID. Can you imagine drilling with bone and blood flying around it? It's an incredible risk to surgical staff. So stay home, adhere to you know, requirements, but also don't be afraid to seek necessary care. Call. Let's be creative, and we can find ways to treat these patients, you know, as effectively as we can with the lack of equipment.
Yeah.
Likewise, for those people who have issues but are not corona positive, they should seek PT first as part of they should really understand what that means, which brings me to my question. What does seek PT first mean?
Well, we should have had Sean explaining that. For people who are not positive, prior to the outbreak, we've had a lot of cancellation of care. Who we were seeing post total hip replacements, post knee replacements, were canceling care because the caregivers were worried that we would be bringing the virus into their home. So that's where telehealth became important, because we can follow up with them, make sure they do the exercises, the range of motion, and all this stuff, and making sure they were getting out, walking. Because even their follow-up visits with the surgeons were postponed because of COVID. Right. So they're in a predicament as well. But they have a right to cancel care, or we can put the therapy on hold. For some people, their therapy has been on hold for like a month and a half, because the virus is still around.
Wow.
The ones who truly need it, but because they're scared, I've had patients ask me if I'm treating patients who have COVID, and I would tell them the truth and say yes. For the ALF sites I go to, I get scanned, my temperature gets scanned. I have to record my temperature every day and submit it. We do a pre-screen questionnaire asking if patients are having symptoms or if I'm having symptoms. And if I display any symptoms or my temperature is elevated, I have to stop seeing patients and
quarantine.
Go in quarantine. So, but people are still scared, even though we are taking necessary precautions not to pass the virus if we are exposed to it to them. And it's causing problems because people are just fearful. They're not seeking care that they would need.
Right. And so speaking of that, the other issue that I was aware of, I don't know if it's still the same, is not every insurance is equal in how it approaches physical therapy. So some people have insurance, but the insurance may not cover physical therapy, or it may inadequately cover it for what's needed for their care. So how do you guys assess and address that particular situation? And is COVID-19 making it easier or harder for those patients if they've been infected and now discharged home?
Visits, well, if you have private or HMO insurance, visits are usually managed. So they will give you probably 3 visits, 6 visits at a time. If the patient requires more, you have to seek an additional authorization for those visits. For Medicare patients, depending on the plan of care that you develop at the evaluation, you consult with the ordering physician to determine the frequency, but the therapist usually determines the frequency. So that's not usually limited per se.
Okay.
The HMO insurance, they have limited visits for patients.
What happens, I know none of you are in New York City, but what happens to the person who had COVID-19, admitted to the hospital, but was uninsured and is now discharged to home? Do you know what happens to that person?
It probably depends on the facility.
Yeah,
well,
I mean,
some hospitals do give 3 visits. Like, I know if you're uninsured and you went to the emergency room before, if you had a stroke or a heart attack, the hospital would request for you to get home help, because if you don't have insurance, you cannot go to a skilled nursing facility or subacute rehab. So they'll give you 3 visits to do at home. So in that 3 visits, you have to teach the patient and the caregiver what to do. And after those 3 visits are done, that's it.
Yeah, for Yale, they've done a couple of things. They have taken the entire student gym and turned it into a field hospital, where they're really using it as a step-down unit for patients who may not have any place to go while they're still infectious, to keep them in a place where they can still receive healthcare. So they may not receive specifically rehabilitation, but there's access to mobility and some exercise pieces. There's also a lot of hotels or other college dorms in the area that are actually being used to house specifically the homeless population or anybody that is COVID positive, to reduce community spread, and make sure that those patients have appropriate health care and housing to promote recovery from the illness.
Wow. You guys are highlighting so many things that most of us are not thinking about, because we're seeing a lot of the front-facing stories, which is prevention, what happens when people don't practice social distancing, etc. But we're really not hearing about this back-end stuff, which is the truly chronic part of COVID-19 that's starting to manifest. That's amazingly scary. Amazingly scary. Now, we're going to keep talking, but we also have some questions. So I want to make sure we get to those before the night ends, including some of your own colleagues. So Lisa Van Hoos writes here, Monique, what is the average cost of the equipment you are leaving in the home? Are you absorbing that cost?
No, I'm not absorbing the cost. The agency that I'm contracting for, working for, will provide the equipment for that patient, usually with referral. Some patients will have to purchase their own. I have on occasion purchased equipment for patients and left it there. So in those situations, I am absorbing the cost. So on average, a blood pressure cuff would cost like $50 to $80, depending on the brand or the type you get. An oral thermometer is probably, I would say, $10 to $20, and the pulse ox is about $30 to $50.
So you could end up spending somewhere between $80 to $125, depending on the needs for the whole patient. Are you utilizing the same services and equipment, Dr. Rich, for your telehealth visits?
Sorry, I muted myself briefly. So we're working on a few different things. Obviously, so for I think Dr. Caruth is discussing a manual blood pressure cuff. Can't really do that. A telehealth model. So we're looking at ways, because what I do in bariatrics is a lot of exercise capacity testing, and we do it from a field testing perspective, that we don't need a lot of equipment, but we do need to be able to measure blood pressure and heart rate and pulse oximetry. Great thing is, within Illinois, we're looking at ways of getting some of those delivered out to patients. Some of them have automated cuffs already in the home, and just figuring out that. So we are using similar things. We also do serial respiratory muscle performance assessment for our patients, and we're partnering with a couple companies now to get that delivered. We'll see where that goes.
Tell us more about what that is. Serial respiratory muscle assessment.
So serial just means we're doing it on everybody, but respiratory muscle assessment. The muscles that allow us to breathe, they act on the chest wall, they expand our lungs. So there's ways to assess it. I actually have a couple of them here. Let me grab them. A bit of a mad scientist, but these are a couple of the devices that we use. This is the Pro 2 trainer. It's our V2 model. We're sending a new one soon. And then the Power Breathe KH2 we'll be using in our research. Patients essentially breathe into these at a maximum capacity. So it allows us to look at the peak pressure they can generate. That has some pretty strong corollaries to exercise capacity, as well as we're thinking about a COVID patient when they are on that ventilator. Yes, it's a way for us to objectively measure, is there a weakness present? And if there is, we can implement training to increase the strength of those muscles. So this has been done in heart failure, COPD, And my area of research is looking at it in a bariatric or a more obese population. So the tough thing is, again, like we would typically do that in clinic, which is trying to get the devices delivered to patients so they can test and we can figure out ways to remotely monitor.
Right. And Lisa Van Hoos also says some are afraid to seek care due to the no visitor policy. Have you encountered that with patients as well?
Yes, patients and actual owners of assisted living facilities, independent living facilities. Some allowing therapists to come in, but you get screened at the door. They check your vitals, especially your temperature. You also want to make sure that you have not been to another facility that has any outbreak stuff that you're bringing it to them. So they prefer to have the nurses come in. A lot of them have cut out physical therapy, but some of them are allowing us to come in, but we must go through the mandatory screening before we actually touch the patients. So, but
physical therapists to go around to accommodate for all those screening measures and see all the patients and get all the patients the care they need.
Some agencies have implemented COVID-19 task force, so you have specific nurses and physical therapists, occupational therapists, speech therapists, and CNAs working only with COVID positive patients.
Okay.
So that reduces the risk of cross-contamination per se. And some of the agency skilled nursing facilities feel better about that. But it's basically because families are worried because they're not able to go in to visit their loved ones.
Right.
They don't want them to have any exposure at all. So it's a lot of pressure on the facilities to actually allow even healthcare workers in.
Wow.
Yeah, I think the research suggests that when you're looking at two equal skilled nursing facilities, when patients are deciding, they choose the one that's closest to their home. So it really tells us that when patients are seeking healthcare, it's really about, proximity to family and home. And the visitor thing is a really important point. So I'm glad that Dr. Van Hoos brought that up. But I also think to Dr. Monique's point that there's a lot of therapists that are right now not working because elective surgeries are a major part of our business model. So we have to be kind of nimble on our feet and be able to repurpose our skill sets away from outpatient total knee replacements and be ready to manage COVID patients. And there's ways to retrofit our clinics to be ready to do that and get therapists kind of on board with being in these dedicated task force. And I think the real limitation is PPE, because we just would be able to open up all of our clinics if we had enough equipment to protect all of our patients. We'd have a lot more therapists kind of treating this population.
Right.
Yeah, a great point. It's not even just a physical resource utilization issue of not having PPE. It's a staffing issue. Most of our PTs, if you look at the percentage, are treating outpatient orthopedic cases. And right now, like you mentioned, like there aren't surgeries, patients. So a lot of these clinics have been shut down with shelter-in-place orders. Many have been furloughed or laid off completely. So it's, we have these very highly trained people. Can we repurpose them to manage some of these cases, or to retrofit clinics to be able to take on cases they wouldn't typically see? Just because we may not have space in a skilled nursing facility. Maybe there's something we can do with these outpatient clinics, training therapists, repurposing clinics to accommodate some of that burden, because it's coming. It's going to be here if it's not here already. So we need to go for it.
How would you refresh or retrain these therapists who've become so specialized, like the ortho, the knee replacement? How would you propose doing that?
I can speak to that because I'm involved in an organization that's doing a lot of this. So within the cardiopulmonary section, and she's going to hate that I'm going to give her out her name because she doesn't like to get a lot of notoriety. It's Talia Pollack, who's our education chair, the cardiovascular and pulmonary section of the American Physical Therapy Association, has launched a project called the PACER Project. which is looking at post-acute rehabilitation, basically exactly what we're talking about. And it's providing summary information on some of the physiology as well as some of the rehabilitation. So it's publicly available on our section's YouTube channel. It's kind of funny because I created the YouTube channel, and we put other things on there. We never thought we would ever have to do something like this urgently.
Yeah.
But yeah, it's research getting out there, putting on the Learning Center. They're free and publicly accessible. Anyone could watch them if they wanted to.
Yeah.
And there's what's that?
What's the website called?
You can go to cardiopt.org or just do a YouTube search for the APTA cardiopulmonary, or just look up PACER project, like PACER, PACER project. It's everywhere and around now. Working with other educational companies like MedBridge and Evidence in Motion to put stuff out as well. So there's stuff coming out there from each society, the European Respiratory Society, the ATS. A lot of the other, the Chartered Society of Physios in the UK have put out, systematic ways to repurpose their therapists. But American PT practice is a little bit different than it is in the UK. So there's resources out there for people to look at, because we have a resource utilization problem within our profession to address what's coming down the pipeline for sure.
Yeah. Mm-hmm. And let's say we have viewers who are in other countries right now who don't really have access to physical therapy. Certainly Dr. Monique and I are from the Caribbean, and there aren't that many physical therapists, particularly doctors of physical therapy, available on island. But they do have COVID cases. They have, for example, in Jamaica, they have 200 plus COVID cases. In Trinidad and Tobago, all the way south, they have 115 at least COVID cases. What can you recommend, Dr. Jason, to communities like that, or the very rural communities where they've made do? The person didn't necessarily need a mechanical ventilator, but they were in the hospital for a long time, and now they need to go home. Is there anything that they can do, or any resources that they can find?
Sure. I mean, I think I had this challenge. I worked in rural Wyoming as a home care therapist for a number of years, and I went to patients' homes with what I could bring in my car, and really got them doing things as, challenging as cardiac rehab for patients who, quote, hated the community hospital and refused to set foot in there. So they just refused to do cardiac rehab. And we would be able to set up their house to be able to do circuit exercise training, things like standing up and down out of a chair 10 times in a row during television commercials is a fantastic exercise for lower extremity strength. Climbing the stairs 10 times, lifting canned food, which can weigh a pound or two, lifting gallon jugs of milk or water off the floor, which are, 8 to 10 pounds. There's lots of household objects and household tasks that can be done. And being able to do those things in a circuit and not taking a lot of breaks in between to get your heart rate up. You can do high intensity interval training like I would doing CrossFit. I can do that in my home, and I've done a few videos like this for the Yale Geriatrics Twitter page, just showing some basic, simple exercises to do. And while those things aren't the optimal, they're certainly better than doing nothing, and they certainly will help preserve or improve muscle strength, protect cardiorespiratory function, and prevent some of these adverse consequences of immobility that are coming from both hospitalization and just from being in quarantine and shelter-in-place orders.
For so long, yes. Dr. Rich, anything to add to that?
Yeah, and I'll add as well, if you have access to YouTube. So I'm bummed you didn't mention Dominica. My dad's from the Caribbean, so.
Oh yeah, I didn't know.
we're a small island, there's like 70,000 people. More people in Dominica live in, I think, other countries.
Yes.
But anyway, I lost my train of thought. Yeah, one of the unique things we've been talking to my colleagues in Kenya, so I did some work over there. They leverage using a lot of stuff that's on YouTube already from the NHS from other countries. So for those who may not have access to a PT, there are certainly things you can find on YouTube provided by reputable organizations. So you want to look at national. Yeah, so the NHS is a big one. APTA's got some great stuff. I think even the CDC has lists of different exercises people can do. So I actually use the NHS as a whole series of exercises for like Jason mentioned, how to get out of a chair for squats and different things like that, that I send to my patients in bariatrics when I want them to like do a workout routine at home. Like, here's a video from this organization, it's publicly accessible. So for those who don't have access, there are some freely available things, but go through reputable sources. You can be wary of what's online.
Right.
On
so by NHS, you mean National Health Service, right?
Yeah.
Kingdom.
Yep.
And APTA would be the American Physical Therapy Association, CDC, Centers for Disease Control. And so I'm actually going to put it up in a ticker as well. But guys, again, listen to this, what they're saying, which is use reputable sites, because what can happen if they actually don't get the right information? What can happen to them?
It's a big problem. It's actually the other side of my area of interest in research and teaching is looking at medical misinformation. I mean, in the United States, I think depending on the statistic you may reference, we've got, 16% of the population is proficiently healthcare literate. A large portion are insufficiently literate.
Yeah.
And it's a big problem because the people who put out misinformation are very good at making falsehoods sound true.
Right.
You really trust in the experts, trust in reputable organizations, because there's people out there that are looking to exploit your fears and looking to make a buck off it. So just be cautious of that. If you use reputable sources, the same lessons you were taught in middle school about when you made your research report, go through the use the .govs, right? Use the .edus. Don't use the
.orgs. Yeah. I agree with that. Now, those who are listening wanted to find you guys. How can they find you? Starting with you, Dr. Rich. Where can they find you? You've mentioned YouTube a few times. Tell us a little bit more about how we can find you.
Yeah, so for my personal and professional account is PT Reviewer. So my website's ptreviewer.com. It's the kind of the mission of that website, and what PT Reviewer is a way to provide free commentary and resources for clinicians. Like, everything on there is for free. I don't charge anything, don't monetize anything. I have a YouTube channel as well with videos I've done for my students that are free if anyone's interested in pulmonary stuff and some other things. And then Twitter, it's at PT Reviewer. On Facebook, it's at PT Reviewer. And then on Instagram, it's at PT_Reviewer. Someone has finally that one.
Awesome. And how about you, Dr. Jason?
I am mostly a Twitter user at this point. I am not cool and don't have Instagram that I use substantially, and not my own website, but I'm at JRayFalvey, so JRAY, and then my last name, Falvey, FALVEY. And don't look for me on TikTok because it's embarrassing. So I'm slowly attempting to be cool and hip, but I'm not there yet. So
a couple days ago.
Trust my research a lot more than you trust my TikTok account.
I have to go look for that now.
Yeah.
Oh, I love it. And Dr. Monique, how about you?
Instagram and Twitter, it's the same. It's at Physio4U, FYZIO 4U. Facebook, under the business page, it's Dr. Monique J. Caruth, LLC. Personal, it's my name. And the website is physio4u.org.
Mm-hmm.
I don't have TikTok. And I won't.
I have TikTok, but I have been reluctant to start. I'm still working my way up to doing TikTok. I really am. I keep checking out other people's stuff, but I haven't gotten there yet. So, Dr. Jason, you're doing great. You're on it.
Yes, I'm getting the. I'll do the savage dance next time we do this together. I'm ready. So,
now, are there any parting thoughts that you want to leave with guests or audience? Of course, I'm going to make sure I didn't miss any questions. I think there are more questions here. But
Dr. Lisa mentioned something earlier. Yes, that.
Yes. So Dr. Van Hu says, would love to see physical therapists used as patient navigators to community providers' resources for post-COVID-19 side effects. Could we set up state regional telescreening stations? It would help decrease the burden on the healthcare system. Well, I like the sound of that.
I can speak to that. Yes, and we're trying to do that here at UIC with our department.
So how are you doing it? For those who are happy.
We have a paper forthcoming on it, so I'm not going to divulge too much, but basically trying to leverage some of the corporate partnerships that we may have and other institutional partnerships we have to basically do that, create hubs for people, for rehab services specifically.
Right. Nice. And if someone wanted to set up a field hospital like you guys have done at Yale, Dr. Jason, is that possible?
I mean, I'm sure it is. Like, there's a lot of spaces and communities that are going unused with, businesses being shut down. So there's, and this is already being done in New York City and other places where they're expecting overflow.
Right.
But I think PTs in general could have opportunities to be involved in treating patients in those settings. And as Dr. Van Hu said, as patient navigators, like we've published work in our, during my PhD and beyond, that we've talked about care transitions and how PTs really are the experts at helping patients get connected with community resources that are related to mobility and transportation, and, getting assistive devices in the home. And those of you who do home care, like Dr. Monique, really are boots on the ground experience in connecting patients with those resources. And they're certainly doing more than just physical therapy. They're often extending the role of social work and other resources as well, which is incredibly valuable and one of the pieces of our role that really lends itself well to telehealth.
Yes. So if you tomorrow find yourself as the head of a policy-making organization for each of you, what would be the first thing that you would do? The one first thing that you would do? Dr. Rich.
I would eliminate the debt of all healthcare workers. It's the first thing I would do.
I like it. Dr. Jason, what would you do that's different? First thing.
Test everybody in the country.
Mm-hmm.
Yeah, universal testing.
Yes, I think until we do the testing and test enough people so we get to that 1 in 10 positive, we're not testing enough people, and therefore we can't possibly know what we're truly, the scope of what we're battling here. We don't know. We're still taking stabs in the dark, and that's scary. Dr. Monique.
I would give physical therapists more autonomy. I think that definitely would reduce the burden on primary care physicians, especially in rural communities, impoverished communities, because we can definitely do detailed assessments and come up with a plan of care, even consult with them in terms of what the patient would need.
Yes.
So definitely more autonomy for us.
What would it take to do that?
Well, you being a physician, we are fighting against the American Medical Association and other lobbyists.
Okay. And what is their argument there? Okay, we'll leave it. Unless Dr. Jason or Dr. Rich wants to take it.
I mean, the argument, and I don't know, I think there's small pockets of resistance. I don't know if this is the overwhelming view of most of my physician colleagues, especially in geriatrics, but there are small pockets who think that there's danger to patients, and I think that is a thought sentiment that's not supported by the research, that physical therapists may miss really urgent or dangerous medical conditions that require emergent medical care more to a greater extent than their physician colleagues. And to be honest, the research really doesn't support that for any condition that I've seen the literature on. So it may be a benevolent concern, but it certainly is not founded in the data. And I think there are opportunities. Physical therapists in the emergency room is becoming an emerging model where they're not where they're not treating patients by themselves, they're treating as part of a team and offloading and helping patients not have to sit and wait for hours in the emergency room with chronic back pain, but maybe be able to be seen and get set up with the appropriate aftercare, which is often not the case in emergency rooms.
Yes. So, I mean, it sounds like the pushback is from those who don't understand the value of care integration. And we just can't possibly all be at the same place all the time. And we're all good at something. And every physical therapist that I've worked with has been tremendous. I use physical therapy, even though I'm a fertility specialist. I use physical therapy quite a bit for my pelvic pain patients, my endometriosis patients, my pregnant patients who are having joint pains, etc. You know, and I think maybe some people would say in the world of women's health, we do it because we're trying to avoid many medications. But whatever the reason, it's beneficial. I know that for a fact. It's beneficial.
And as a home health therapist, we do the differential diagnosis when we go into the home, and we actually save physicians from a lot of stuff.
Yeah.
Even the surgeries, if we forgot to put the patient on an anticoagulant, or an PTNR is high or low, we can prevent the patient from getting a pulmonary embolism, detecting signs of a stroke, or even a possible patient going into possible cardiac arrest or diabetic coma. We've done that. So there is actual evidence that our expertise and training is valuable to become famous. So
yes. Well, I'm a huge advocate, and I hope most of our audience has recognized why physical therapy has a role and why it's critically important. But more importantly, why we're underutilizing physical therapy in many ways at the moment. Any parting words before we say goodbye? And thank you so much for everything that you did tonight.
Well, I'd say that just let's use this this situation, this pandemic, as a starting point to address some of the issues that have manifested that made this a much worse problem that it could have been. The infrastructure within our healthcare system, the existing health disparities, this overall poor health of our nation. Like this is staring us in the face, and either you do something to address it, or we're gonna fall victim to the same problem and the same happens.
Yes.
So we need to take this as an opportunity to, hey, let's look at these things and let's address them. Not only just for the good of preventing this pandemic, but it's for the good of society.
Just to general health.
Yeah. We get the most out of society if everyone has the best opportunity to be successful and healthy.
True. Dr. Jason, any parting words?
Yeah, I want to say that surviving COVID-19 is not the end goal for most patients. Surviving is really the beginning. Patients overwhelmingly want recovery of physical function and the return to their normal daily activities as part of their medical goals of care. So we really have to start not just focusing on survival, but we really have to focus on recovery of physical function and quality of life and making sure everybody has access to that care. Otherwise, we're going to really have a massive wave of high disability, which is going to place a substantial burden and cost on the healthcare system going forward.
Absolutely, absolutely. And I don't hear anyone talking about that yet.
And we talk about it's going to have a huge burden on the economy too if you had that many people out of work. We talk about that and how that shelter in place is affecting the economy. When you get a ton of people with significant disability, they're not working, they're not. That's a big concern as well.
Dr. Monique.
Well, one of my biggest things that I wanted to advocate for was health disparities, and unfortunately, well, I should say it's a blessing in disguise that COVID-19, this pandemic, has highlighted how severe that health disparity has been.
Yes.
And unfortunately, even though some patients recover, the ones who have been hit the hardest because of the health disparities are gonna be in that same position or even worse in the long term. And we have to work on implementing policies to improve access to care and funding for patients who who have been struggling with it.
Yes. Yes. And for those who are watching and listening, it's really important that you follow the 3 doctors that are on tonight, in part because they do a lot of advocacy work on social media, especially Twitter. I've been following all of them, and they are working hard every day to highlight these issues, bring it to the fore, and also to really get our stakeholders involved and to recognize the issues. You know, it's not always their fault, the stakeholders, because they may not be aware. It's important that people bring awareness to them. And these 3 doctors of physical therapy tonight do that, and they do it very, very well. And I want to thank you guys. I'm going to just showcase some of our, in the last minute here, what our audience has been saying, because they are also very grateful. Dr. Lisa says, thank you, Dr. Monique, for discussing that issue. Irma says, that's true, Dr. Jason. Someone's joining us from Trinidad. Miss Cora says, I said Dr. Cora, that's hilarious. I love this session. And really, I have to echo what the audience is saying. And we've consistently had over 50 people viewing across all platforms. And I know it'll review over and over. I would love to have you guys back as we get more information about what we're seeing out there, to talk about how people are doing and are they truly recovering. I know it's still very much acute outpatient, even because the people are only now starting to go home from many of their hospitalizations. And I just wanted the audience to hear, because all we're hearing about is COVID-19 and that front part of the story. And we have another wave coming, separate from further outbreaks, etc. What's coming is this disability. And what's coming is disability in communities that are already struggling with disparities, struggling with inadequate access for disabled patients, people struggling with inadequate access to services, food, medication, now going home further disabled and unable to work when they were barely working paycheck to paycheck before. So we have a big issue coming, and I wanted the audience to hear this, to know that we don't take this lightly. It's not just about wearing your mask. It's not just about, I left the window open again. It's not just about, you know, people talking about fake this or fake that. It's not just about that. It's really about what we're going to see long term in our communities across this country and across the globe. And it's time to take stock. Even if you're doing well at home, there are other people who this is just not, it's not working out the way you think it is. It's not just the flu. They're not febrile, pain, better, back to work, back to school. That's not what's happening here.
That's
my guys. So I am going to just play us out and we'll be done.